cerebral dural fistula أو ما طولش إن شاء الله. Starting with a very brief anatomy of the dura mater, which is the tough mother, consisting of two layers, the outer endosteal layer and the inner meningeal layer. A quick view over the dural venous sinuses. It's an endothelial lined spaces between those two layers and draining into the internal jugular vein. We have the diploic and the emissary veins draining into these dural venous sinuses. The veins of the brains are doesn't have any muscular tissue and no valves. They lie directly in the subarachnoid space and drain into these dural venous sinuses. The emissionary veins connects the dural venous sinuses with the diploic veins of the skull and the veins of the scalp. And the blood supply of the dura maters differs according to its place in the anterior cranial fossa, mainly supplied by branches from the ophthalmic and the ethmoidal arteries, and the middle cranial fossa from the meningeal, ICA and the ascending pharyngeal arteries, and the posterior cranial fossa branches from the occipital and vertebral arteries. The dural AVM, it's an abnormal connection between the arterial and the venous side of the vascular tree located on the surface of the dura. A very important thing that the nidus of the AV shunting is contained solely within the dural leaflets. This is distinguishes the AVF from the pile AVM. Here, as you can see, the fistulous point, this is the arterial phase, and this is the venous phase. Just as a quick scheme for the dural AV fistula, this is the red circle, this is the abnormal connection. The red arrow here, this is the arterial side. This is the last normal site of the vein, and all of this is the thrombosed sinus. It carries a 0.17 per 100,000 persons, comprising about 10 to 15, 12% of the intracranial vascular malformations. It's usually solitary in presentations, can be multiple in 6.7%. A quick review on the pathophysiology, it was used to be thought it was a congenital process. Then venous hypertension theory was developed. First, there's thrombosis of the sinus with the diversion of the flow entering those venous sinuses, allowing an enlargement and expansion of the pre-existing microtrunks. Then there is recanalization and diversion of the arterial flow into the cortical veins. The most common locations are the transverse sigmoid sinus and the cavernous sinus, followed by the superior sagittal sinus and the anterior cranial fossa and the tentorial dural fistulas. Carotid cavernous fistula and the transverse sigmoid dural fistula more common in females, while the anterior cranial fossa and tentorial dural AV fistulae more common in males. Classification mainly depends upon three things. First, the direction of the flow. If there is any reflux in the subarachnoid or the cortical veins, are those veins dilated, or there is reflux in the perimedullary veins. We have two main classifications, the Conyard classification and the Borden classification. To start with a quick review on the Borden classification, it's more simplified and it's usually done according to the flow only. Borden type 1, as you can see, there is a flow in the sinus itself or in the secondary veins without any reflux in the cortical veins. Starting from Borden type 2, there is reflux in the cortical veins. Borden type 3, there is no reflux, no flow in the sinus itself, but only isolated cortical venous drainage with or without ectasia or perimedullary venous drainage. Conyard classification, a little bit sophisticated. Conyard type 1, there is just antegrade flow in the sinus. 2A, flow in the secondary veins. 2B, there is reflux in the cortical veins. 2A and B, we have both flow in the secondary veins and the cortical veins. Conyard type 3, there is thrombosed sinus and there is only reflux in the cortical veins without antegrade flow in the sinus. Conyard 4, there is ectasia, and Conyard 5, there is perimedullary spinal venous reflux. This is an angiographic diagram for Borden type 1. This is a transverse sigmoid sinus and dural fistula with antegrade flow, and there is no reflux in the cortical venous veins. Borden type 2, this is again a transverse sigmoid fistula. There is antegrade flow in the sinus and reflux in the cortical veins. And this is type 3. There is no antegrade flow in the sinus, only isolated cortical venous drainage. We have a lot of variation in the symptoms. The most common symptom is the non-aggressive symptoms, which is the pulsatile tinnitus and the headache. The aggressive symptoms are the intracranial hemorrhage and the non-hemorrhagic neurological deficits. The predictive predisposing factors for aggressive symptoms are mainly for the venous drainage, the leptomeningeal venous drainage, the varicose or the ectasia, the galenic drainage, or if there is a stenosis or occlusion of the associated venous sinuses. And also the location, we have found that the fistulae in the tentorial, incisura, or the anterior cranial fossa tends to be more aggressive. This is a quick overview for the symptoms and the presentations according to the type of the fistula. The cavernous fistula mainly presented with ocular symptoms. Transverse sigmoid sinus and superior sagittal sinus fistulae mainly presented by headache. The tentorial fistula is mainly presented by tinnitus, and the anterior cranial fossa usually presented by intracranial hemorrhage. We have an overall risk of hemorrhage of 1.6% per year, with a wide variation of the morbidity and mortality from 1.8 to 20%, and 35% risk of rebleed within the first 2 weeks. Benign fistulae can thrombose spontaneously after angiography or compression. The management options, we can just observe this patient if it's a non-aggressive type, usually in Borden type 1 and Conyer type 1 and 2A. Transarterial embolization, mainly favorable in the benign, less aggressive lesions. Transvenous, mainly resorted to the aggressive lesions. This only can be done after having a good DSA and showing that the involved sinus is not used by the brain, and alternate pathway of the venous drainage is developed, and also there is the surgical approach. Before treating a dural AV fistula, we have to know the risk of the dural fistula for this patient and his symptoms, and the key point is the venous drainage. We have to know the venous drainage very well. This is a quick overview. The benign types, Borden type 1, Conyer type 1 and 2A, will observe the patient unless he has symptoms. The other types are the aggressive types, should be treated. Our treatment, the curative treatment, is occlusion of the primary draining vein, either through the arterial or the venous side. Here is the antegrade navigation through the arteries, and here's the retrograde navigation through the veins. The aim is to the plug and to close the draining vein. According to the types, as we said, type 1, it's a benign fistulae. Don't take any therapeutic risk in treating this patient unless he has very severe symptoms, intracranial hypertension, or risk of transformation, as we said, in the venous stenosis or occlusion. This patient should be treated without any risk, so we can go to the transarterial side and preserve the sinus patency because it's a functioning sinus. Type 2A, we have a risk of intracranial hemorrhage, papilledema, and risk of venous dementia, but also it must be treated only if they have severe symptoms. Again, we'll go for the transarterial approach and try to preserve the sinus patency. Our aim here is to either to cure the patient or even to reduce the flow to let the patient adapt with his symptoms. The more aggressive types Conyer 2B, 3, 4, and 5, and Borden type 2 and 3, there's a risk of hemorrhage and venous infarction, so it must be treated. This is a case of type 5 causing progressive myelopathy by MRI images. In the aggressive types, we have to treat either by the transarterial or the transvenous phase. This is done after doing a good DSA to know the patency of the sinus and whether it's a functioning sinus or not. If it's a functioning sinus, we have to do a transarterial approach and preserve the patency, while if it's non-functioning, we can occlude the sinus. Just a quick overview. If we have a Borden type 1, Conyer 1 and A with no cortical venous reflux, if the patient can tolerate his symptoms, we just observe the patients. If there's no change, we continue with a serial of MRIs, MRA, and repeat angiogram after 3 years. If the patient have worse or better symptoms, we have to repeat the angiogram. If the patient cannot tolerate his symptoms, we have to do a palliative treatment, mainly by the transarterial approach. Borden type 2, Conyer 2B or A and B. If the patient doesn't have any neurological deficit, we have to access the venous phase on cerebral angiogram. If the sinus is not used by the brain, then we can go for obliteration or excision of the sinus, or we can just do the cortical venous disconnection only. But this is mainly resorted if the the sinus is used by the brain. We have to go just for the cortical venous disconnection and preserve the sinus. If the patient has neurological deficits, we have to interrupt the feeding arteries only through transarterial approach. Lastly, Borden type 3, Conyer 3, 4, and 5, no neurological deficit, access the venous phase again. If there's reflux in the cortical veins not used by the brain, we can just do cortical venous drainage disconnection, transvenous approach. If there is reflux in the cortical veins used by the brain, we have to interrupt those feeders mainly through the arterial approach. If there is neurological deficits, we have to interrupt the feeders and preserve the patency of the sinus. Thank you.
Dr. Ahmed. Any questions? We move on to the next talk, Dr. Khalid